We're very excited to have Amparo Gonzalez present on culturally relevant diabetes care for Latino population. Amparo is Senior Director, Global Professional Education for the Johnson & Johnson Diabetes Institute and a past president of the American Association of Diabetes Educators. Prior to joining Johnson & Johnson, Amparo was founder and director of the Emory Latino Diabetes Education Program, a multi-site, clinic-based diabetes program at Emory University and accredited by the AADE. Amparo was also co-director of the Emory Diabetes Education Academy, a two-day diabetes training program for entry-level diabetes educators. It's my pleasure to welcome Amparo. Amparo, the floor is yours.
Thank you, Mary. So I am delighted to share with you my knowledge on the expertise I obtained through my work with Latinos and Hispanics with diabetes at Emory. It's so nice to hear Mary tell all those things, and you think, oh my God, that's been a long time, and it was a fascinating time in my career. So let me share with you what we're going to discuss today. I'm going to give you background and context, especially talking about some census data and trends in population growth. I'm going to discuss the state of diabetes in minorities, not just Hispanics, Latinos, but give you some information on different minorities. Of course, we're going to be discussing culture and healthcare. Who are this group of people that speak Spanish? What's common about us? And in making sure that we address the DSME issues, I'm going to use the framework of the AADE-7 to share with you some tips on assessing patients and how to develop some strategies when working with Latinos. And very important, communication tips, especially when communicating with low English proficiency patients. So we're going to have a very fascinating next 1 hour. So the goal of our program is to further develop your development, your skills and expertise in using culturally appropriate interventions for Latinos with diabetes. The objectives for today are that upon completion of this presentation, you will be able to discuss the burden of diabetes within the Latino population. You will identify and apply the American Association of Diabetes Educators' self-care behaviors as a framework for your education process. You will really be able to identify the important areas you will be able to zone in when assessing your patient, and identify culturally appropriate education interventions in the management of this group. So we're going to review a little bit your geography. This is a map, and this is a map of a little bit of North America, Central America, and South America. This comprehends the Americas. So I took the time to really mark the countries here that speak Spanish, and we're going to go through them. So if we start on the left side, you start with Mexico. You have Honduras, El Salvador, Nicaragua, Costa Rica, Panama, and Guatemala. We have the Caribbean with Cuba, Puerto Rico, and the Dominican Republic, and then South America. There are a couple of areas here that are interesting to point. And one is that the largest country in this continent is Brazil, that although it does not speak Spanish, it is considered, because of all their characteristics, these patients could be considered within this group we call Hispanic Latinos. Now we have a country in Central America called Belize. And this country is very British. So although they eat the same and their physique is very close to the rest, their customs are more British. And we have three countries that are in gray, right over the big one that is Brazil, on the right side of South America, and those are the Guyanas, and they speak French. And then there are many islands that speak English, and we don't consider them in this group. Let me talk about the census. And the census, as you know, is done every 10 years. Our last census was in 2010. Unbelievable that we're already in 2016. We're 6 years into this census. And that census counted in the U.S. 308 million people. 16% were Hispanic Latino origin, which is 50 million people. There was an increase from the previous census in 2000 of 35%. The countries of origin with the highest growth was Mexico, that grew from 20 million to 31 million, Puerto Rico from 3 million to 4.6 million, and Cuba from 1.2 million to 1.8. So as you can see, there's a tremendous, significant amount of people coming from Mexico. Let me point out that if we start talking about immigration and illegal immigration and these type of issues, Puerto Rico and Cuban immigrants always come with you having, these people come with legal status. So it's a different situation. There have been different immigration waves. If you go back and remember how this country was founded, we had waves of immigration coming from Europe. We've had waves of immigration coming from Asia. The current wave of immigration, 50% of the people coming into this country are from Latin America. So that is significant. If you compare that, half of the people are coming here are speaking Spanish, and the other half are the rest of the world. And this is data all that you can find from the census of 2010. Let me address one issue that I don't know if you are all wondering. I've been using the term Latino and I've been using the term Hispanic, and sometimes I use both of them. When I do this presentation on this topic, I love to have an audience, a live audience, in-person audience, because I love to see these reactions. The term Hispanic Latino is used by the government. In the 70s, when the census started to measure this group of people that spoke Spanish, the term that was utilized to group us was the term Latino. We've come a long way. In the census of 2010, finally they realized that Hispanic is an ethnicity, that there's Hispanic and Latino, is a personal identifier. Some people prefer the term Hispanic and some people prefer the term Latino. But this year the census in 2010, the census had the question asked race, black, white, Asian, and then ethnicities. Plus, it also asked if you were from multiple ethnicities or multiple races. So you're going to find that I will continue to talk about it. I love to ask the question, and if there are any Hispanic or Latinos in the audience, I would love to hear what is your preference. We have an open question at the end. But I prefer Latino. I come from Colombia, from Latin America. For me, the term Hispanic is something I had never heard before. And I love to tell the story that when I came to this country in 1987 and went to the Social Security office, and they asked me, are you Hispanic? I wonder, what is this term? But I checked white, because I am a white Hispanic or a white Latino. Latino for me is an ethnicity. So I messed up the census data from in 1987 when I came. So let's continue. Enough of that. So we have a polling question. Mary, it's all yours.
Well, thank you. I'm going to go ahead and read the question, and then we'll push it. So the first question asks, by the year 2050, the Hispanic population in the United States is expected to include how many millions of people? A, 62 million, B, 73 million, C, 102 million, or D, 137 million. So we're going to go ahead and push the poll and let our attendees take a few minutes or a minute to answer that. And in the meantime, Amparo, would you please share with our attendees while they're answering the question how you got from your training as an RN to the place where you're so deeply involved in the diabetes world?
So briefly, I came into this country, like I mentioned, in 1987, being trained as a nurse in Colombia. It was very hard to validate my title here. I had to take courses and classes and learn a lot of diseases I had never heard of. Took my boards in Georgia and started working as a staff nurse, where they introduced me to diabetes education, fell in love with it. They trained me, and that's where my career started, from a patient educator to the director of a beautiful outpatient diabetes program at St. Joseph's Hospital in Atlanta.
Fabulous. You certainly have had a fabulous career. Well, I've seen that the majority of our attendees have answered the question. I'm going to give everybody a few more seconds, and then I'm going to go ahead and close the poll, and I'll push the results and let you speak to them. So let's go ahead and close the poll. And I'm going to push the results, and Amparo, would you please address it?
Okay, so small group saying 62, 73, 102, and 137. So yes, the right answer is 102. Let me show you where this comes from. So this is a graph from 2010, from the census in 2010. The light blue are actual numbers. So in 1970, 9.6, 1980. 1990, I was already counted in this one. There were 22 million. 50 million in 2010, 47.8. And remember that we're only counting the people that are allowed to be counted, which we are assuming are legal. There's an estimated 30 million people that are unaccounted for. Call it that. But if you see the projections up to 2050 are 102. Let me just say that illegal immigration has decreased. And when we went through our latest finance trouble in the U.S., many Mexican people here went back home. So it'll be interesting to see if these projections are really continue to grow in the same estimate, or if it's lower. I'll really look forward to seeing the census in 2010 to see what happened there. So what's the state of diabetes in minorities? The highest incidence in diabetes is, you all know this, African Americans, Hispanics, and Native Americans. Prevalence is twice as likely in Hispanic Americans and African Americans than in white, in non-Latino white. We've heard this over and over and over. I just want to make sure that we're all talking on the same page. Now, complications, diabetes-related complications, including eye, kidney, amputations, heart, and stroke, happen mostly in African Americans and Hispanic Americans. We're finding in countries like Mexico, people are diagnosed with retinopathy and have blindness or close to blindness, very low vision, and they have not been diagnosed with diabetes, or they're diagnosed at that time. And very high levels of kidney disease and people on dialysis. Now, we also have found from studies that Mexican American women participate in little or no exercise. We had no role models. We had no athletes. Our parents, our mothers did not exercise. My mother and my grandmother never wore any kind of sneakers or any kind of active shoes. So that was not what we saw growing up. It's changing. So we're finding very high of obesity in African Americans and Hispanic Americans. We're seeing it in children with these same two groups. So what is the state of diabetes in the Hispanic Latino population? And I'm using Hispanic Latino here because this comes from the CDC, and that is the term that the government uses. They're twice as likely to be diagnosed with diabetes than not Hispanic whites, and you're going to see that this is the term used by the government, not Hispanic whites. Higher rates of end-stage renal disease, and 50% are more likely to die from diabetes than are non-Hispanic whites. Another question.
Okay, so thank you, Amparo. The next question asks, the prevalence of diabetes among U.S. Hispanics/Latinos is positively correlated with increasing years of living in the U.S. So I'm going to go ahead and push that question and let our attendees take a few seconds to answer. And in the meantime, you were just talking about legal immigrants in the United States and the numbers of them, and the fact that illegal numbers are going down. Do we have any sense of the percentage of diabetes that we're seeing in the illegal immigrants who are still residing in this country and they're getting their health care from somewhere? And I know we're seeing some diabetes because I see that in my own clinic.
Yes, so it's twice as much as a non-Hispanic whites. So Mary, I am a white Hispanic and you're a non-Hispanic white. That's the difference. So it's about 30% of people. No, hold on. Let me go back. So you want to know how many people with diabetes are Hispanics?
No, I'm thinking more of just the general illegal population and the illegal immigrant population in the United States. Do we have any sense of the diabetes? And many of them are, of course, Hispanic or Latinos.
Yes. So, so what's easy about there's a lot of diabetes in this population, and it's twice as much as what you find in the non-Hispanic whites. So if non-Hispanic whites is about an 8%, you're going to find twice as much in this population. And the people those that are illegal have no access to ACA or Obamacare, so they're still accessing healthcare in free clinics and those type of clinics or healthcare that was that has been available. Those are the programs that I established at Emory. We were getting some people that had health insurance that were not illegal, but that were low literacy or people with still underserved. And the program was in Spanish. It has to be, you need to keep in mind the low numeracy and low literacy and develop programs that are very, very simple because of the literacy level. But you find, and I'm going to talk about that in what's coming up, how this group, what are the issues that you want to keep in mind with this group. So you're going to be, it still fascinates me as I go through it, about all the things that we don't even think about that happens within this group.
Perfect. Let's go ahead and close our attendee poll, and then I'm going to push the results and ask you to speak to the results of this question.
So, yes, it is true, and let me show you why. So this was published in Diabetes Care in 2014, and they looked at the disparities among U.S., Hispanic, and Latino. So those are people that are here, that moved to this country. And the prevalence is higher because of poor nutrition. We've seen other studies, some done in Texas, that family, when both parents work, start adopting fast food up to twice a week. That's where poor nutrition comes in. We get fascinated with these fast food and snacks, and where we come from, we've been cooking from scratch, and then we change our diet. Very low levels of physical activity. I mentioned that before. I had a patient at our clinic, at our LDEP program at Emory, who had diabetes, and she told me that when she was back in Mexico, she used to be a shepherd of goats. So imagine that. She would go up and down the mountain all day. Once she came here, she sits in an apartment watching TV all day. Obesity. We tend to add significant amount of weight when we move over to the U.S. The availability of food. I remember getting dizzy the first time that I went to a grocery store. The amount of chocolate contributes to that. So next I'm going to show you something I am really fascinated with. And this is the Iceberg Theory of culture. So this concept, we've seen the concept of iceberg being used in many other ways. But it's being used for this. And it's being utilized to demonstrate that the concept of culture on the surface, you see a very small demonstration. And the deeper you get into, you find more of the core values of that person within that culture. Just like an iceberg, we think of characteristics as the observable behaviors of a group. What are those? The food we eat, the music we listen to, the dance we dance to our music, our expression through art, our greeting rituals. Let me take a minute and talk about greeting rituals. A simple one is greeting through kissing. I work in a global role right now, and when I get together with my global peers, I have to remember, is it one kiss, is it two, is it three? And I love when they kiss me 2 or 3 because they know I kiss in the cheek, but people get confused, so it's fascinating. All of these are external manifestations of deeper and broader components of culture. Now, if you look at the graph and you see the water line, the behaviors that you see are over the water line. Below our interpretations of those, and deep are the core values, the good or the bad, the right or the wrong, the desirable versus the undesirable, the acceptable versus the unacceptable. So complex ideas are deeply held preferences, and priorities known as attitudes and values are kept below the waterline. You need more time to learn and more digging to really find them. The core values are included like attitudes towards age, social status, modesty, views on raising children, concepts of fairness. So I'm going to give you a little activity here. I want you to think about your personal definition of fairness. I've talked to people about this. I'm going to give you a second to think about it. How do you define fairness? When I've talked to different people about this, and we're talking about fairness towards our children, some people say when I buy a present, I buy all my children the same thing. I personally think that I give my children what they need. So not everybody gets a present when I come back from travel. If I find something that one likes, I'll get it for that. But then next time there may not be something. So you see how different that can be. I don't know what yours is, but think about it and compare it to these two I just shared. So approaches to problem solving are very personal and ingrained in your culture. And think about this when you're working with people with diabetes, because problem solving is extremely important when you're doing diabetes self-management, when you're teaching it and when you're doing it yourself. So make sure you address issues around problem solving. Notion of cleanliness, very different. And I will leave you with cleanliness. When you travel, different smells, people that bathe in the morning, people that bathe at night, it's very, very culturally based. Another concept that is different is leadership style and gender roles. So I'm going to leave you with that because I could talk about this the entire time. I want to talk about assessment of health beliefs. And this is fascinating. I will have, when the slides are posted, a list of resources, and you'll find some very interesting around this. But let me share with you some of my experiences. If you ask a patient, what do you think has caused your diabetes? And you get the answer, eating sugar, the Twin Towers fell, my brother died. How do you answer? This is a very real and valid response from your patient. And I used to answer, no, that's not true, until I talked to Guillermo Pierres, who was my colleague and co-founder of the program at Emory, and he said, you know, we really haven't proven that. The way to go around is, we know that's a stressor, we know a stressor could trigger hyperglycemia, but diabetes was already there. You just didn't know you had it. So I really changed my story. You know, ask a question, how does diabetes work? How serious is your diabetes? Do you think it will get better soon? How many times you've been asked the question, can I stop my metformin, my blood sugars are normal? That goes with this question. And what concerns you most about your diabetes? To really address issues about complications. In Latinos, what you're going to hear most is blindness or amputation. One more question.
Alrighty, so for our final polling question, it asks, which of the following is not an AADE 7 self-care behavior? A, being active, B, reducing risks, C, coordinating care, or D, problem solving. I'm going to go ahead and push that question and let our attendees take a few seconds to answer. And in the meantime, we had a question from one of our attendees, Amparo, who asked what you thought about the word undocumented.
Actually, that is, the reality is that these persons are here illegal and they have no documents. There are many words to call them. You could call them illegal. You can call them undocumented. I kind of like undocumented. It still shows that they're illegal, but in a softer way. I don't think the group minds. They know they're here. They worked very hard to get in, and I probably shouldn't get into politics, but I've heard the stories, and someday I'll tell them to you. One day for a Christmas party, we decided, one of the patients started telling stories about how they had got into the U.S., and the stories, I started to cry. People had tried 7 times until they finally made it. They paid all this money to come, join their families. It's a sad story. I wonder what we would do if we were put in a situation where we had no money to raise our children, and we knew that past that door we could find the best country in the world. So it's wrong they come, but sometimes you can blame them. It's great to see what they make of themselves, and how the children grow up, and the great things they give back.
Thank you so much for sharing that. Okay, let's go ahead and close this poll. And I'm going to go ahead and push the results for you to see and let you address them. Alrighty, can you see the results?
I am very happy to see that. As you know, I have been raised the AAD as a diabetes educator, been involved with them for many years, so I love to see that you all got it right. Although coordinating care is a very important part of our jobs as diabetes educators, it's not one of the self-care behaviors. I don't need to go into this. But for the few of you that didn't get it right, I just want to say that this is the work of the American Association of Diabetes Educators. This is a framework that is to be used to assess, teach a language, to measure diabetes education. So I will skip, but I am going to use not all of them, but some of them to share what I've learned about Latinos. So let's start with healthy eating. And healthy eating, in the case of Latinos, the biggest issue for me is time and name of meals. I'm Colombian. I was dealing with mostly a Mexican population when I was doing my work in Atlanta. And I was very proud teaching inpatients when I was an inpatient nurse. And most of us eat 3 meals. And most of our meals are right, breakfast, lunch, and dinner. Well, my patients coming from Mexico, after about a year of doing it wrong, I learned that many patients coming from Mexico, rural areas, or people that are from low income, eat 4 meals a day. They eat a meal at 8, a meal at 10, a meal at 2, and a meal at 8. And I've since learned that in rural areas of the U.S., this also happens. But what also happens is that they call the meals different than what I call them in Colombia. And I'm going to name them in Spanish for those of you that know some Spanish. So desayuno would be a breakfast, the first meal of the day. An almuerzo would be a noon meal of the day, normally. And dinner would be a 6th meal of the day. But my patients from Mexico eat a desayuno, which is breakfast at 8, a lunch at 10, a dinner at 2, and a supper at 8. So for years I was teaching them wrong. So what I would suggest, and what I do now, is I just call the meals by, I ask them what times are their meals and call them by the time they eat them. Because we're so used to calling them what we call them that it gets very confusing. So be aware of that. You're going to find that patients have a preferred meal by their regions, and it's very geographic. You're going to find tortillas in Mexico and Central America. And then you find other starches until you get to South America where we have arepas. But it's very interesting that if you don't specifically ask people that eat tortillas, how many tortillas is your dose of tortillas per meal, they will totally forget to tell you about them. And the person has a dose. They will eat either 2, 3, 5 tortillas at breakfast, 5 at lunch, 5 at dinner, to half a kilo, to an entire bag. In Mexico and Central America, tortillas are used for dunking, for grabbing the sauce and eating without utensils. So that makes for a lot of tortillas. They don't realize that tortillas are starch. They're more concerned about chile, which is a pepper, raising your blood sugar, than really tortillas. So just by getting that little bit of knowledge into them, you're going to see a huge improvement. Now, adopted foods. If I was to ask you to raise your hand to ask you how many of you eat tortillas, probably all of us will raise it. We've all learned how to eat Mexican food. They've learned how to eat spaghetti. They've learned how to eat rice and many other things. Now, food labels. As much as we complain in the U.S. about how unhappy we are with our food labels, most of the countries in Latin America don't have them, or they're measured in very high levels of numeracy, not by portions, in grams. So it is a good opportunity to teach them how to read food labels here. Sources of carbohydrates, I mentioned that already. And then we are a very social group, so make sure you address issues about alcohol, special events, because every opportunity to get together with friends and family is a huge meal for us. Being active, I already told you we don't do it. It's very gender specific. You're going to find that the women love to dance, the men will play soccer. I had a very interesting opportunity to take one of my patients, I gave her a scholarship, train her as a Zumba instructor. I started bringing her to teach Zumba, and guess what happened? All the women got up to dance, and all the men sat around us to watch us. And I thought, this does not work. So then we started working on getting our men to play soccer in a weekend league, and that worked. So be very aware of what happens. Different barriers. I'm going to talk more about acculturation, but this is an opportunity to discuss. Acculturation is how people that come into the U.S. or any other country adopt the mainstream culture and keep some of our native or mother culture. So you're going to find people that go to the gym are much more accultured than people that are still not exercising. Access to different types of activities, time because of work. But let me tell you a model that I found extremely valuable. I don't know how familiar you are with a herbal product called Herbalife, but these people probably exhausted all kind of U.S. consumer groups, and then they targeted the Hispanic Latino group. And they go into apartment complexes, and they go to their activity room, and they meet with these people that are interested in drinking their product at breakfast and at lunch. And they make it a social event. Everybody comes down, they sell their drinks there, or you bring your own drink, and people come and get together. I think that would be an amazing model to copy for diabetes, for exercise, for teaching eating, and for many other things. So what we did at Emory, we had a peer support, a person with diabetes, and we had her going to the meetings in her building and meeting with, talking to the people about eating and diabetes. So let's move to glucose management and financial barriers. Again, insured versus uninsured. So you need to be very careful of how you explain the importance of monitoring, and that you're going to talk to the group of uninsured about how important it is that they carve within their budget the money they need to test, and make sure you develop a testing schedule that really meets the needs of that person. Using the results, you need to identify their treatment and their meal schedule, and you're going to create a test that could be once a day, twice a day, or you test the 2 weeks before the appointment, or just come up with very creative opportunities to do that. The technique, there's no problem with that technique. They learn how to do it. They love. Now you have to make sure they're not sharing that meter and they're not wasting their stress in testing the entire neighborhood. One big issue here is the sharps disposal. If you have people coming from rural areas in the third world countries, they don't know the concept of waste management, so you need to make sure you teach them how to dispose of sharps. Very, very important that they don't put them in the toilet or in the trash. So let's move to the next one. Taking medications. Oh, I can talk about this for a long time. Name and action are side effects the same for, there's no difference between your non-Latino patients and Latino patients. Now, meds from country of origin. You need to ask directly. What are you bringing from home? What are you using it for? I've been in this country close to 30 years and I still bring medicine from home. I'm a highly educated healthcare professional. There's something about feeling you close to home that you do that. I had a patient at Emory, at Grady. We diagnosed him with diabetes. Blood sugars were extremely high. We put him on insulin. He goes home, calls home, tells them to send him medicine. They sell him some kind of a combination of chlorpropamide and metformin. Did not take his insulin. Here I'm calling him, finding out how he's doing. Sugars are up and up and up. I finally brought him back and said, tell me what's going on. So he told me. So I said, okay, that's not going to work. You need to go on insulin, and then you know the story. Once we get your sugar normal, we can see if we can drop it. Then you can go on an oral, and that's how we did it. But people are extremely fearful of insulin. Not just Latinos, African Americans are too. They believe insulin causes blindness and amputations. They probably know somebody that knew somebody that went on insulin after having years of diabetes, hyperglycemia, and extremely high A1C, and they went blind, and they find the cause to be the insulin and not the diabetes. Please watch when you're prescribing medicines, or take a look at the insulins that are prescribed and make sure they can afford them. I have patients with a couple with one prescription for metformin, one took the first half of the month and the other the second half of the month. I don't know whether they just spread it out through the month, but you need to work with them and help them figure it out. Let's talk about problem solving and healthy coping. So we talked about health beliefs. Empowerment is a new word in my culture. We don't know what it means. It doesn't go with what we think. We're not empowered. We still think healthcare is in the 50s. The doctor tells me what to do and I follow the orders and I just say yes. So very, very pay a lot of attention. Find out who is the decision maker in the household. Again, I'm talking about acculturation. Do not ask your patient, are you accultured? You're going to find out how many years have they been here. Do they speak English? Do they relate to other cultures, so they stay within their culture? Do they still work with a Hispanic business? I only speak Spanish. That's when you're going to know if they're really able to problem solve and cope. Knowledge about the healthcare system. Latino patients are used to going for an appointment early in the morning and waiting to be seen. In Colombia, doctors have appointments at 10 p.m. at night. I don't know how they sleep. So they don't know the concept of making an appointment and sticking with it. So work with your patients. Explain to them how it works. Transportation. Do they use public transportation, or do they have to pay a high fee to have a taxi? A Hispanic taxi, take them. We talked about insurance. Time orientation. We are always late. And we've covered immigration status. So let me talk about communication tips. If you're going to learn anything today, I want you to learn that each one of you, have to develop and build self-awareness. You need to know what is under your waterline. Print the slides, take that, and look at the things that are underneath, and get to know yourself. To establish a therapeutic relationship, the most important piece is to build trust. And you do that in your first visit with your patient. Look at them, talk to them, learn their name, know what's important to them. Learn how to pronounce their name. Speak clearly and slowly. Don't raise your voice. We're not deaf. We're just don't speak your language. And we understand more than what we can speak, so always make an effort to speak slowly, even if you're using an interpreter. Include some familiarity, and this goes to maybe asking, once you get to know them, about their children or something about their personal life. But let me include here something about eye contact. Eye contact is extremely rude for us. So if you see your patient, if you're looking at them directly in the eye and they're looking down, don't force your eye contact on them. Just soften it up, wait till they come back to you, because it's disrespectful for us to look somebody in the eye. And you, as a healthcare professional, you have a higher authority, so it is disrespectful. Excuse me. I talked about incorporating some type of touch. Maybe as you're walking your patient from the waiting room or in your classroom, you can lightly touch them in the arm if you're comfortable with it. That goes a long way in building trust. I want you to practice your active listening skills. I want you to be aware how frequently you are listening to your patient, but you can't wait for them to finish talking for you to tell them what you've been thinking about you want to say without really listening. Be aware of this. Practice mindfulness. Practice being in the moment and listen to what your patient is saying. You learn a lot from them. It's important that you teach in small chunks. So a little bit, make sure they comprehend it, give some examples, have them tell you back what they learned. Don't do a whole class in English. Do not sit your non-English speaking patients in your English speaking class. Don't. Not even with an interpreter. It doesn't work. 3 hours of teaching and then somebody's going to tell them what it said. I would love to talk to you individually if you're doing that and help you figure something else out. Now, the most valuable piece of strategy that we can use is the teach back technique. It's when you ask the patient to tell you back in Spanish or in English what they learned. And use it frequently. And what I am going to spend 5 minutes now is on how to use a medical interpreter. Extremely valuable. Let me give you some background. From the census in 2010, we also learned that there's more than 25 million people living in the U.S. that defined their English proficiency as less than very well. Less than very well is not very well. This population, we know, has decreased access to health care, and we also know that there's a Civil Rights Act that mandates that interpreters need to be provided to this group of people. So when you're using an interpreter, I hope you all have access to interpreters. When you're using them, you as the clinician should address the patient directly. Do not talk to the interpreter, you talk to the patient. Let the interpreter sit behind or to the side of the patient. Your statements should be short. How many times you speak for 5 minutes and the interpreter takes 10 interpreting? You have no idea what they said. Discussion should be limited to 3 major points, and make an agreement with your interpreter that they're going to limit to only say what you're saying. You can also make an agreement with your interpreter that they can serve as a cultural liaison. Then you know that you're going to be told some things about the culture, and the patient is going to be told some things about what they're expected to do. If you are limited to phone interpretation or to use bilingual staff members, those are okay alternates. Never ever use a child family member from that family. I will provide you with some opportunities on some references. And in summary, I want to make sure you have individualized your education plan. Don't stereotype. Oh, this is a Latino, I learned this from Amparo, this is what I'm going to do. No. Take the time to know your patient and develop a very, very individualized plan. You're going to assess a consideration, and include a consideration. So you're going to find out when they came, what they did, story about how they got here. Don't get into the illegal or other things unless you already have cross relationship with them. And the word to use it softly is, do you have papers? That's the term to use that will take you to undocumented or illegal. Develop cross-communication skills. This is for you. There's a lot of things, and what you're learning from me should help you do that. Be self-aware. This is what's going to allow you to have cross-communication skills, because as you know who you are, then you understand that people that communicate different from you are just different, and you can understand that. And I can emphasize enough about using the teach-back strategy. Use it every time, and you will be very surprised about what you hear of what that patient understands. Learn from the experience, and you'll be able to have amazing relationships and teaching and learning opportunities with your Latino or Hispanic patients, depending on what they prefer. So this ends my presentation, and we have one more question.
So Amparo would like to have you all share with us what diabetes, self-management, or communication tips that you can share with us that you use when working with the Latino community. So we want you to ponder that for a few seconds. And in the meantime, while folks are thinking, Amparo, there have been a couple of comments and questions. One comment gave you great kudos for handling the question about documentation very well.
Oh, thank you.
And our next comment also stated, having handouts in Espanol is very helpful, even if you have an interpreter. Pictures are worth 1,000 words. Food labels in Spanish/English, portion size, eat this instead of that, are all great illustrative handouts. So,
yes, they are.
Any comment on that?
Don't assume that they speak Spanish. They may be illiterate in Spanish, or they may speak a different indigenous language. We have in Georgia, at least, we had a lot of people from the Ribera Maya that spoke dialects. So ask them if they speak Spanish, find out what is their grade level. At the Emory program, our grade level was 3rd grade. It wasn't even 5th. So find out. But let me tell you that, and I don't know if this is still current, but the ACP, the American College of Physicians, so the internist group, has a beautiful book that Novo sponsored, and they put all the effort in health and literacy and numeracy, lots of pictures, little writing. So if you have friends that are internists, you could get up to 25 of those books for free. So I would encourage you to look at that. The Emory program has beautiful tools, and you can reach out to the LDEP. You can Google. There's if you go to Google and you Google Emory Latino Diabetes Education Program video, you'll have access to videos in Spanish that you can use for your patients. Very well done. We won an award from AIDE.
Fabulous. So anybody who has any reactions to this question on the screen, we would ask you to type it into your Q&A box. In the meantime, I have a couple more questions for you. One of our attendees asks, we know that there is a difference between language in different areas. We have Spanish and Puerto Rican materials because there are different terms used, and having 2 languages reduces confusion. And she references the TMF Health Quality Institute. So I think that was similar to what you were just talking about with different languages.
So there is...
And then, go ahead.
There's one language which is Spanish, but just like in the U.S., you have different accents and different slang. It is fascinating. We had Puerto Rican neighbors to find that we name fruits and veggies differently. And we both are sort of Caribbean. You're going to find that for banana, a lot of different words. Plátano, guineo, bananito, banana, very, very individualized. So don't assume that it's different, but yes, you will find that Caribbean, so if you work mostly with Puerto Rican and Dominican, as happens in Pennsylvania where I am now, you will want to do a more Caribbean Spanish. If it's Mexico and Central America, close to Mexico, you probably want to bring a more Mexican type of content. But if you just do Spanish, do a neutral Spanish. Colombia has a very neutral Spanish, Bogota. So you may want to find somebody that from that area that could take a look at what you've got.
Okay, so one last question, and then I'm going to ask you, Amparo, to open up your Q&A as well, because there are some comments I think you may want to address. The question is, when doing a telephonic assessment, is it offensive to a Latino to ask what the highest level of education is?
Well, I would be tactful, because it is a stereotype to think that Latinos, the overall group of Latinos, is uneducated. So I would do it in a tactful way, such as up to what grade of education did you complete? But no. I think the same with reading. Can you read well, or can you read this, or how well can you read? Just like what you asked the question about adherence, you're not going to say, so do you really take your medicine every day? No. How How many times a week do you forget to take your medicine? You assume that it happens. So be tactful. So I have incoming questions, but I have 12, 13, and 15. How do I get to the rest?
If you hit on, 12, 13, and 15 are the comments to your slide. The other questions have already been asked and answered or attended to. So these are the comments we want you to address in the final 2 minutes that we have.
Perfect. So we have, Judy tells us that she tries to use non-medical terms, images and pictures, and also important to promote a shame-free environment. Absolutely, not judgmental. So let me share with you like the definition that we would use for diabetes at the Emory program. We would just say diabetes is high blood sugar. And high blood sugar, and this is, when your sugar is higher than this is when you have diabetes. We don't do pancreas, we didn't do any of that. So yes, I also encourage you to use myplay.gov. They have it in Spanish. Miriam, your name tells me you may be from this group. I tell them diabetes is not from eating too much sugar or too much food. I explain that they have diabetes, not that they are diabetic. Beautiful. Just like you don't have cancer. Absolutely. I love that. Vicky Carnes, you're here. Thank you. Vicky, come a long way from Georgia. I love sharing about ATA's year-long living. Living with type 2 diabetes, ATA has a great program in Spanish. Up to 50 copies of the Where Do I Begin booklet in English and in Spanish. So ADA has books that you can order 50 for Spanish. Excellent. Oh, Patty has no sound. Sorry, Patty. Ruth. Encourage the whole family. Absolutely. So Vicky Carnes, who has helped us at the Emory program, we encourage patients to come with their entire family. To bring the children. We have toys the children can play. And we would have very, very huge programs. We would have programs on Saturdays that would, they were very well attended. You have to make it comfortable for them to share. You speak Spanish. It is better to use a lower level of professional, an MA, a peer that speaks Spanish, than to have a physician that needs translation. It's more important the language. You can have the physician there, but make sure that somebody that speaks Spanish can do the teaching. And I think we've answered all the questions.